Hi, good evening, everybody. Back to another webinar. It's Wednesday, 9 p.m. And I have here with me my ex-classmate in university previously. We were both in UKM. And this is the first time I'm meeting her face to face, and again is online. Sharifa actually specializes in endometriosis. Her passion, she wants to change the way we think about period pain. And also her passion is, the other passion she is very passionate about is actually keyhole surgery, right?
Yeah, minimally invasive.
Yeah, minimally invasive. She is always trying to improve on that. I follow her on Facebook. I see her progression. As you know, we doctors have to progress all the time, even no matter what age you are. And she is one example of it. She's always pursuing something. And once she pursues, she imparts knowledge to everyone else. And I think without further ado, we will listen to her webinar. And come, let's start.
Okay, thank you, Betty. Let me share the screen. Yep. Okay, you see my screen?
Yes.
All right. Let me just put this side. Okay. Right. Okay. Thank you, Betty, for that short and sweet introduction. Okay. And I also see Betty for the first time. We are Facebook friends, and finally we met now on Zoom. And all right, without further ado, and again, thank you for actually inviting me to share this knowledge and about endometriosis and treatment. But I decided to just perhaps look into in young women instead of overall. Yeah, well, it's quite a big topic, if you're just talking about endometriosis and treatment, because the endometriosis got so many subtypes. But I think I will just touch those important one, and those that perhaps any new informations that may be relevant to your practice. Yeah. So yeah, to start with, endometriosis can occur in young women and associated with distressing and debilitating symptoms, and even though some are asymptomatic. So the cardinal sign is dysmenorrhea. So do not underestimate dysmenorrhea, chronic pelvic pain, dyspareunia, and dyschezia. So these are the four main symptoms of endometriosis in the spectrum of it. And sometimes painful urination if it's involved the bladder. Infertility is one of the main component as well. Abnormal menstruation and other gastrointestinal upset, diarrhea, constipation, and so on. If it's involving the bowel and also the nerve, like hypogastric nerve, that's supplying the bowel, the ureter, and the bladder. Yeah, so the way we describe this pain is not just normal pain. They are pain, suffering, and debilitating. So the thing about this disease is that it affects 10 to 15% of women in reproductive age group. So it means these women are young women. They are young women. They're just starting their life, young women. So that's why this disease is so very important. It's a chronic, inflammatory, and progressive and recurrent disease, estrogen dependent, and it is also affecting now almost 190 million women worldwide. And if you look at the breakdown, according to those studies, survey people have done, 40 to 60% of women with dysmenorrhea has endometriosis, and almost 50% has infertility, and also 70 to 87% of women with pelvic pain has endometriosis.
Sharifa, do you mind using the slide, enlarge your slide?
Okay, yeah. Oh, okay. Yeah. All right.
Perfect.
Yeah, so sorry.
It's
yeah.
Okay.
And it also associated with the impaired quality of life, for the fact that this disease is affecting women the whole lifetime, the reproductive lifetime. I mean, this reproductive lifetime is their prime time. You know, this is the time that you want to build your career, you want to build your family, you want to do a lot of things, right? When you energy. But this is the time these women are actually engaged or prisoned by the disease, by the symptom, pain and infertility and so on. So it affects quality of life and a significant socio-economic burden as well, because, you know, and they keep on going hospital and have to, you know, pay costs and all those and so on, frequent absent from work and thus poor work performance. And then not only that, this disease, you know, the recurrent rate, medical or surgical intervention reported around, whether you do medical or surgical treatment, you know, around 30 to 50% in 5 years. So the disease is making a coming back. So it's like the time that you've been diagnosed endometriosis, you're never free of it until you menopause. 64% of women have endometriosis symptom more than 30 years. And this is according to studies, yeah. And over 60% of women diagnosed with endometriosis have increased risk of multiple surgeries and higher chance of developing ovarian cancer. So these women, you know, not only that they're having pain that limit their activity, limits their dreams, you know, and what they want to do, but also at the same time, they actually run the risk of multiple surgeries during that period of time. And also at the end, they also put them at risk of ovarian cancer. So when you look at the spectrum of endometriosis, it is ectopic growth. We know that this ectopic growth of the endometrium, you know, of a different spectrum. I mean, they are not in the endometrium, right, in the cavity, but now we have the endometrial-like cell is somewhere outside the uterus and behaving like endometrium, where they are actually sensitive to, supported by the estrogen and continue to cause chronic inflammation. So, and they have many spectrum of it. So you can have, you know, we call it endometriosis, like pelvic peritoneum or superficial endometriosis, which involve just a peritoneum. So they have two types. We have atypical lesion, usually it is commonly at the beginning in young people most of the time, and it also can happen in older people, but most of the time in the younger adolescent. So they are just blisters, red brown kind of lesion, very sometimes can be missed, and just about 3 millimeters, 1 to 3 millimeters, you know, below the on the peritoneum. But the typical lesion are slightly bigger, and they actually more older version, you know, so typical lesion like a powder burn. So this is a bit more older version, older. So, but they are still in the peritoneum, within the peritoneum, you know, not below 5 millimeter down, because so. And then you have endometriosis of the uterus, adenomyosis. We call it adenomyosis because now the endometrium just break through the junctional zone into the myometrium. So then they actually develop another clone of endometriosis called adenomyosis itself. Actually, is another. And now we have agreed that we actually put adenomyosis to another entity, despite they actually have same pathogenesis. And another one is endometrioma, which is endometriosis of the ovary, yeah, invagination of this endometrial-like tissue into the ovarian cortex, and then forming a cyst, and then with the deposition of fibrin, iron, you know, and then destroying the ovarian cortex and the follicles, and risk the women of infertility and so on. And also they have the most severe form is endometriosis of the rectovaginal septum or uterosacral or vaginal or parametrium rectocervic, which is the 5 millimeter deep below the surface of the peritoneum. We call it deeply infiltrating endometriosis or adenomyosis external. So this is the one that I think now in our somehow here, I find that it's a bit, many people overlook, you know, this deep endometriosis because, you know, it's difficult to treat, and, you know, it's even if they have to go for surgery, is a high risk surgery. If you look at this picture, you see that this woman, this is a young woman, she's only 26 years old. Look at, she has almost everything. Look at her uterus. And then look at this thing, you know, so you look at that, you know, see the bowel is attached there, you know, so she has rectovagina, she even have rectal endometriosis there, you know, fibrosis attached to the retrocervic there. And you can see here is the endometrioma, And you can see some are actually, those shiny lesions, they are actually blisters. So this patient has all the 4 entity, and the uterus also have adenomyosis. So these are young people, okay? So these are young people. So Professor Philip Konix, had done the studies. I mean, Philip Konix is one of those professors who've done so much studies on the endometriosis. Is an expert. So one of the studies involving the adult of nearly 4,500 people of endometriosis, and look at, on the ovarian endometriosis, actually only 35% of the patient has single endometrioma, but 50% of patient with ovarian, if you see patient with ovarian endometrioma, actually have deep endometriosis, 50% of it. So, but the thing is that most of the time, people only treat the endometrioma. People don't treat the deep endometriosis. But it doesn't make any difference, if you don't treat the disease as a total, because I explained to you later, and almost 75% of the endometrioma also have a typical lesion, and then 15% have a sub. So you can see that actually, it is a multiple disease. The disease manifested in many ways, in one presentation, and see, even though adolescent have more subtle disease, but not necessarily they don't have a deep disease. Depend on the age of their menarche. The earlier the menarche, the earlier the onset of this endometriosis, what they call this, bleeding, retrograde bleeding, the earlier the onset, the faster chances that they get deep endometriosis. So, and you look at the pain symptom that the patient have. So they have they don't have like single dysmenorrhea. So it's not just period pain. So they have many other pain at the same time. So look at the actually all overlapping pain that the patient have, not just period pain. So sometimes the patient has, if you ask the patient, I have a patient who has only functional for 1 week, over a month. So 3 weeks, she's non-functional. She's busy managing her pain. So the first week, she's busy managing her pain before period. 1 week before period, she's having severe pain. During period, severe pain. After period, also severe pain.
Oh my God.
So that can last her about 10 days. And then after that, her chronic pelvic pain continues. And dyspareunia. I mean, if you have husband and this and that, so sometimes women don't even communicate or articulate their pain, and they just, well, I have to do my duty. So this is how women, that's women actually, endometriosis, actually young women, and they are really trapped in many ways due to pain. So the thing I want to tell you about here is about this theology, even though I think this is poorly understood. But I think now people has come up with this, a better explanation of the theory, which actually help us in managing our, give us some direction of the management of the patient with endometriosis. So the earlier theory was a Samson theory of retrograde menstruation, but somehow this theory is no longer acceptable as a main cause of endometriosis because every woman have retrograde bleeding. Every woman has retrograde menstruation, but not everybody have endometriosis, right? Only certain people have endometriosis. So it doesn't really explain very well, and it also doesn't explain endometriosis at other places as well. So of course, they have an immune dysfunction, lymphatic spread, and so on. They actually interplay and this and that. But I think they're very interesting now is genetic epigenetic mutation that actually, as the theory that seemed to be promising in helping a lot of perhaps prevention, and also give us a direction of the treatment. So the thing is that about endometriosis cell, they are not just endometriosis cell, they are progenitor cell. They actually a clone. It's a clonal lesions. I mean, from single lesion, progenitor cell, where they can actually multiple from the mono, it become it multiply. So and every lesion, if you look at every lesion, they are different. clones. Like, for example, deep endometriosis, you have endometrioma, you have subtle, you have a typical lesion. If they actually sample it, and they actually come from different clones. So when different clone mean that they have a different behavior as well. So these are they are actually a clonal lesion. And the thing about endometriosis, actually, they are predetermined. The imprinting gene, it same like diabetes. I mean, they are inheritatory potential. They have hereditary potential. Similarly, endometriosis and infertility as well. So the gene has been imprinted, expressed whether paternally from the paternal side or maternal side. When you're born with this genetic defect, inherited defect in this gene, in particular gene, in that layering the endometrium, the base layer endometrium, perhaps you know some people may have, some women may have this defective gene. So when this defective gene, actually, when she become menarche, she goes to menarche, then she exposed to another environment that perhaps bring to the manifestation of the disease. Like, for example, the pollution, oxidative stress, the retrograde menstruation that she experiencing, causing chronic inflammation, oxidative stress, perhaps the diet that she's taking, that, and then radiation, and the lifestyle and infection also. That's very important. People are talking about vaginal microbiomes now in teenagers, that perhaps modify this epigenetic that could actually express those genetic defective inherited gene into endometriosis. So again, they have their own variability, so depend on the types, and also, of course, the estrogen production and progesterone resistant as well, because some of the clones are probably progesterone resistant, like subtle lesion, because they are just at the peritoneum. So they actually most of the time they are progesterone resistant, so that most of the time, if you give them OC, perhaps you will grow the disease, because the patient is estrogen resistant. The estrogen will act on the disease, make it more severe. So this is the theory that being described, epigenetic theory, where endometrium act like a stem cell, like a bone marrow cell, with inherent genetic and epigenetic defects. So usually, they just, when they have retrograde menstruation, you have this gene defect, they just stay there in the stick or the peritoneum there, and they just stay there, and then the body can clear it. Our immune system should be able to clear it. Many people, all of us have it, when during our menstruation time, but the thing is that for those people who are susceptible or predisposed to the disease, so this is where they will have genetic or epigenetic changes, from the defective, because when they are exposed to this abnormal environment, example, the peritoneal cavity, where they have all these oxidative stress taking in place, all those inflammatory mediators, and bleeding, and infection, and so on. So this thing that changes the abnormal environment in this peritoneum will actually change that clone, and wherever they are, into this different endometriotic disease. Typical lesion, it can be cystic lesion, deep lesion, and other lesion as well. So this is how we understand it. So it's something that, at least when you look at here, there is something that, where we can apply some prevention. Okay, I mean, yes, if people have like people who are having diabetes, right? I mean, you're having diabetes, so maybe you have to control your diet. You should not take sugar. You should exercise, and so on. So at least, there's something that it can explain, in the prevention, and how understanding also the way how we treat. So the thing about this endometriosis, you see, when they from single clone disease, like the single clone, and then eventually when they predispose to oxidative stress or microbiomes that actually modify or stimulate this clone to become multiclonal, expansion of the clonal, and they get blood supply. I mean, they create their own blood supply, angiogenesis, so capillary, so they become their own community. So the thing is that, the specific cell, I mean, so they may have different cell may have all this at a certain point, they may have progesterone resistant, or they may have their own mutation, like cancer driver or aromatase, able to escape from a immune mechanism. So the thing is that our body able also trying our best to limit the disease. So that's when they have chronic inflammation, there will be fibrosis. So fibrosis actually is a good thing for us. I mean, that means our immune system work. If not, the endometriosis will end up fill up the whole abdomen like cancer, right? So fibrosis actually work like a wall of trenches, where actually try to like a abscess, they try to close everything in. So the army cannot go in, and those go in cannot go out. So they just trap inside. Okay, so but the thing is that with the fibrosis, because we have the organ, we have the nerve, the pelvis are highly innervated organ. You have a sympathetic, parasympathetic, somatic nerve, crossing, wires here and there, and they get trapped in the fibrosis of the disease. So that's why sometimes the pain, can be due to fibrosis. They can be also become a disease. So and so on. So it's like even though it is part of the body, belongs to the body, but it can become complicated because of this fibrosis, especially on infertility. When you have fibrosis, adhesions, your tubal ovarian function is affected, people cannot get pregnant and so on. Okay, subtle lesion. You see that studies have shown that actually 100% progesterone resistant. So this one you must put back in mind, about progesterone resistant, especially when your patient doesn't really shows any improvement when you put them on OCs or on progesterone. This is very important, because it could be having some progesterone resistance. So the thing is that study, this also has shown the early menarche here associated with endometriosis as part of the risk factors, and candidate genes for age at menarche are associated with endometriosis. It means that the earlier the menarche, they could also have a gene for endometriosis. So it actually expressed together, perhaps. So that's why they have a hereditary similarities, 51%. So the thing is that also these studies also have shown that about the relationship infection, as the potential cofactors that modify this genetic predisposition into manifestation of the disease, higher prevalence in the chronic endometritis. So what we're supposed to learn from here is that if the young women having abnormal period, or the possible infection, it has to be treated. You have to treat the infection aggressively, because if not, they will end up, as we do not know who are having defect disease, right? But the thing is that, it's good to look at it seriously, so that it does not manifest into endometriosis disease. So chronic endometritis and and so on. This is just a study to show that relationship. And also the relationship with the oxidative stress, like inflammatory mediators, inflammation, it can be in the form of infection or retrograde. The more you have retrograde menstruation, the more, especially people who have young teenagers who have heavy menstruation, these are the young people who are potentially going to have endometriosis if they have a defect, if they are predisposed or susceptible. So young people with heavy menstrual bleeding have to be treated aggressively to prevent, because when they have more retrograde menstruation, so they will have local inflammation, increase in all reactive oxygen species that contribute to all this manifestation of the disease, and also development of a new capillaries and so on, and crucial to the endometriotic lesion development and so on. So so this is the very important. So actually understanding this, also is good, because some people now developing like maybe we should start antioxidant early, like kind of supplement for these young people, which is potential. Now people are looking, I think scientists, a lot more studies going to come with regards to microbiomes, or regards to antioxidants, as part of the ways that we can actually delay or arrest this disease, at its formation. So this is also another show that age and endometriosis diagnosis. If you look at here, these studies, look at this, the age is here, and those people those patients, those younger they have more what do you call this, subtle lesion, okay. But you see, most of the time as they enter, beginning they just subtle lesion, but as they grow older, see that the disease, because retrograde menstruation continue to happen, and then of course delay in diagnosis, and people were thinking period pain is not normal, or they may not have period pain, but some may have period pain. So you can see that the disease, actually, they are not progression of this one subtle lesion, this typical subtle lesion into typical lesion or into deep endometriosis. No, it's just as another clone, another retrograde menstruation, another defective endometrium somewhere and grow into something. So it just like, you can see that, you see, at the peak age is around between 20 to around up to 40. And this is a very prime age, and they have not only one disease manifestation, they most of the time have all the 4 diseases together. If you look at here, see, they have deep and cystic lesion, deep endometriosis and cystic lesion together, and also they also have some superficial lesion. So endometriosis, so we cannot take endometriosis as just one lesion, or just ovarian cyst, chocolate cyst. No, most of the time they have other lesion need to be cleared. So the learning point here is that, okay, this is a learning point, okay, from this new theory, understanding endometriosis is hereditary. Okay, you have to ask family history, who else in your family, okay, is a mother have endometriosis, then you can know that, okay, there is a potentially that their children also may have, the female. Is inherited defective genes, initiation of the disease. See, last time we believe, last time during my medical school, but if you remember, we only know that people who had obstructed, reproductive system, like abnormal uterus and this kind of thing, only going to get endometriosis early, last time, but the thing is that we also see so many people older in the slightly older young women, but they also have endometriosis. They doesn't have abnormal uterus. They don't have biconate uterus. They don't have obstructive system, but they have severe endometriosis. So how many? So the thing is that now we know it is not so true. So yes, that's also true in a way for people who has, but the chance they're highly susceptible. But the thing is that anybody without a normal uterus also can have, because everybody have retrograde menstruation experience, and those who have defective gene will have initiation of this endometriosis, at the menarche, and slowly grows, and it associated factors. Okay, these are the factors that actually hopefully we can change it. Like for example, early age of menarche, we can stop the period, right? So we can delay the period, is right? I mean, something that we can do, delay the period into, say, instead if their period on 10 years old, perhaps we can give something that the period, come at 12 years old, or heavy menstruation you can treat. So these associated cofactors that will manifest the disease, those who are susceptible, chronic endometritis and ovulatory cycles. Why? Because an ovulatory cycle is just like they have high estrogen because they are lacking of progesterone, right? Because there's no ovulation. So then these are the one who actually going to grow endometriosis, stimulate endometrial cell. So, and vaginal microbiome dysregulation. Okay, so for those who have, so don't ignore young girls who have abnormal period. Vaginal discharge and early sexual intercourse and all those kind of things, changing in their bacteria, in vaginal flora. Oxidative stress, so this relate to the retrograde menstruation. So these, I think, the factors are something that we can look into in our management of patient, so something that we can arrest or we can delay, if the patient come early, as long as we don't tell the patient period pain is normal. So this is the thing that we want to change. Period pain is not normal, something that we can do to arrest the disease. So progressive and aggressive, this learning point, but self-limiting disease complicated by fibrosis. It's a self-limiting, which is good, so that it doesn't grow the whole body like cancer. It's just like, but the thing is that the fibrosis itself can be a problem. Severe endometriosis is not uncommon in young women, and each lesion is different and clonal with varying degree of progesterone resistant, especially subtle lesion can be 100% progesterone resistant. Okay, so that is that learning point.
Can I ask you something first? What is, you keep on mentioning retrograde bleeding, right?
Retrograde menstruation, yes.
Menstruation. What does that mean?
So your period instead of going down, so some part of it goes to fallopian tube and bleed in the peritoneum.
Oh, I see.
Yeah. Okay. And we have that also, but the thing is that, I mean, we doesn't have endometriosis, we doesn't have pain. I mean, this is like, it can be, it's painless. It's not like painful thing. So they call retrograde, it's going to the back.
Oh,
So,
I see.
yeah.
I
So
never
these are the
knew
things. And
that
then they carry this defective endometrium cell outside, and then they get implanted there, and there the stories goes. So, okay, diagnosing endometriosis.
Oh, sorry. In this retrograde hemorrhage, retrograde menstruation, they carry the cells that can implant the endometrial.
They carry the defective endometrium cell.
I see. Okay, you can go on. It's very interesting.
Yes, yeah. So, okay, now how do we diagnose endometriosis? I mean, this is also an issue, diagnosing. Diagnose is a gatekeeper to therapy. The earlier diagnosed, then we can prevent the disease, severe disease, right? So we can control symptoms. So the problem is that diagnosis delay is endometriosis is so rampant. Okay, people take, studies have shown that there's average delay to 7 years. In fact, last time it was 12 years. Now it's shortened to 12 years. So long delay, this from the start of symptom to the first consultation, it takes 1 to 3 years. And then after that, it takes another 3 years to actually making a diagnosis. Why is that so difficult to make a diagnosis of endometriosis? Because people associate period pain with gender. Oh, period pain is normal. Everyone say the same narration. Your mother, so I think, what did your mother tell you last time? Or what did you tell your daughter today? The same thing, okay? Period pain is normal. Everybody goes having it, okay? When you deliver baby, when you get married, you deliver baby, the period will go. So this is the direction that people give, and then people thinking, yeah, period pain is normal, and people think their period pain and other people is the same. So this is a problem. So, and it's very hard to change this kind of culture narration. It's not only here in Malaysia; it's all over the world. So that's the thing. So the thing is that it takes time, to even people to go to see a doctor because they think that this is normal. Then after that, even that, the doctor also will tell, I mean, it's very common, right? They will tell, oh yeah, this one period pain, no important. So they don't go through those other symptoms. And even the women may have some bowel symptom. So the doctor will just focus on the bowel symptom, ignore the rest of the other period pain and this and that, just treating that as a bowel irritable syndrome, interstitial cystitis, and whatever those things, but endometriosis. So that's a problem, so they take a 6 years delay. So by the time this woman come to see us, they're already in 20, so that's when they already have the complication of the disease, all manifestation of the clones already expressed in this patient, and the pain, infertility is also a become issue. So this is just to show the symptom onset, so people around 25 to 45 years old. So these are the time that people are presenting, or even though diagnosis or the symptom actually has come much earlier. So the third is from acceptance. Why is it delay? Acceptance of symptom and misdiagnosis contribute to endometriosis diagnosis delay. So people wait 2 to 3 years before seeking medical attention because they get confused, over normal and not normal. And then also frequent misdiagnosis. Everybody want to diagnose all these things, bleeding disorder, irritable bowel syndrome, food intolerance, and everything. And all these women, 74% of women receive more than one false diagnosis. It's so difficult to diagnose. People don't want to diagnose women with endometriosis. So these are the things that it is the studies that people have done. Yeah. So the thing is that because the people study has done, so many studies has been done. Survey has been so many, and then that's affecting so many young women future. Future, they want to be something, but they are trapped in the pain. I mean, I want to become army, I want to become this, I want to become those physically, even, whatever. I mean, how to do the job when you are only functional for 2 weeks, and the other 2 weeks you're busy managing the pain. So, and that only that it affect the interpersonal relationship, married relationship, and social, and unable to go socializing, and there's so many implications. So, and people have known that. So that's why I think in 1929, because the thing last time, because reluctant to make a diagnosis or thinking that period pain is normal, so people want to have to get laparoscopy, diagnostic laparoscopy before labeling the patient having endometriosis. So because of that, so patient doesn't get the right diagnosis, and then doesn't get the right treatment or right attention. So now we actually, there's a new shift of paradigm, 29, that we say a call to action, that we doesn't need that anymore. I mean, okay, it doesn't matter about laparoscopy, straight away start treatment. I mean, they give algorithm, okay, like algorithm this way, algorithm clinical diagnosis. So we diagnosis now, actually in teenager, is clinical. I mean, any general practitioner in the clinic should be able to diagnose endometriosis and start the treatment straight away. Okay, so, and start treatment straight away, only, I mean, that you have to assess. 3 months, the pain is still there, the patient is still, the pain doesn't go below 5, then you have to refer for diagnosis laparoscopy. I mean, you don't put patient forever, because somehow we need to arrest the disease. If the patient is still having pain despite 3 months on hormonal treatment, so or no improvement at all, or pain score doesn't reduce, her quality of life is still affected. So I think she deserves to get a diagnosis laparoscopy or proper assessment. So these are the.
Hold on, sorry. So you would recommend a 3-month empirical?
That is according to the consensus, according to the consensus statement, Strasbourg recently 2002. So they have agreed that on this consensus that, at the primary healthcare level, so you should try 3 months. 3 months, if they're doing good, continue taking, because you see, the aim is to give them a long-term care, and then they shouldn't be 3 months and just let them be by themselves. No, I mean, they have to be followed up, ultrasound has to be done, and this and that, and also to see the progression. Remember that medication is only to control symptom. It doesn't treat the disease. It just controls symptom. Keep it there. And then the patient to be pain-free, they get quality of life, they get things they need to do, and this and that. And also, they don't treat the disease. I mean, the medication cannot treat fibrosis, right? I mean, the fibrosis doesn't get medication. Endometriosis is a surgical disease. It's not a medical, not even a medical disease. So medicine is only to control symptoms. So don't think that the medicine going to, or give patient the wrong idea that medicine going to cure them. It's only to hold the disease is where it is, perhaps bring down the inflammation and so on, so the swelling and so on. So these are the symptoms, that they have to evaluate. Every patient, you must ask them, dysmenorrhea, what's the pain score like? Deep parosmia, what's the pain score like? Period pain, pain during period, during past motion, what's the pain score? All these pain score, you have to give the patient pain score. So infertility, review patient history, whether they have infertility, previous history, when they have the first dysmenorrhea, and whether they have, so all these details, this is all the algorithm for diagnosis, and then you do vaginal examination. But the thing is that if masalah is very easy, I mean, they're all sexually active, you can do vaginal examination, but our people is not. So it's like, if they come with us, we cannot do vaginal examination, we cannot even do vaginal scan. Also, that is become a problem. That's why diagnosis laparoscopy, we cannot say, oh, we cannot be done. Because
are you sure they're not sexually active, or they're lying about not sexually active?
I should tell the patient, are you single, or single mingle, or you single with partner?
But most times, I don't believe that they're not sexually active.
Yeah, but I always check their, the hymen and this and that, so I always ask them, and I mean, usually, we will know how to know whether they are really, because usually we cannot go and push our tongue just if they're single. So usually I will label myself, label my patient, single mingle mean that no sexual activity, single with partner. So it means that they already have sexual activity. So, okay, what is the best modality to diagnose endometriosis? So don't diagnose with CA1 to 5 or that kind of thing. So it doesn't work because CA1 to 5 not specific, not, it's sensitive for many things, but they are not specific for endometriosis. I may give you some idea, but not diagnostic too. So there are many non-specific symptoms because sometimes endometriosis, even the patient, they may not have dysmenorrhea, but they have pain during period, they have pain past motion. When during period, they have pain when they pass urine, or they may have some discomfort, constipation, and that kind of, so you have to think also that could be endometriosis as well, because maybe the bowel, get additions and all this and that at the back of the uterus. Non-specific, they have no specific marker, no, like say 1 to 5, no specific marker, and lack of awareness. So that's a problem, yeah. And then also the stigma, symptom of normalization. So we have, we want to send patient, we can't send everybody for invasive diagnosis, isn't it, right? So we don't know which is the best modality. So now I think people are proposing that transvaginal scan and MRI perhaps actually are equally sensitive, equally with a good positive predictive value. But the fact that actually TVS, actually repeatable office procedure, dynamic and cheap, perhaps this is supposed to be the first line that everyone with the period pain or anything that's a symptom of endometriosis should have transvaginal scan. But that's why I said the issue is that comes when they have subtle lesion, they are very young and they're not sexually active. So this is a thing. But I think you have to still make a diagnosis by clinical. Perhaps you can give diagnosis, or the preliminary diagnosis of endometriosis and wait until many years. I mean, when let's see whether is there any more sign that she's going to have in the future. MRI is available, is good, especially if he doesn't have the ability to do TVS. So actually MRI actually is also good modalities to do. So non-invasive ultrasound, important because again, I mentioned to you, accessible, acceptable to the patient, you can perform earlier diagnosis and you can repeat, and then, you can choose to the appropriate treatment after you do. Because sometimes, the vaginal scan also needs skill. I think our general practitioner, perhaps, I'm not sure if anybody have learned transvaginal scan, but most of the time transvaginal scan is done by the gynecologist. So, but even in the gynecology, so not all can do vaginal scan to detect deep endometriosis. We can do ultrasound to detect cysts, we can detect, adenomyosis, but when it comes to deep endometriosis, so we need extra skill to detect that because sometimes many of us cannot see what beyond the uterus, all bowel, ureter, sometimes we cannot see. But now we actually encourage people to learn, especially the gynecologists, to be able to diagnose deep endometriosis by the ultrasound. So, also it's important. And also if we know that we can counsel the patient and so on, okay? So now, can TVS replace diagnostic laparoscopy? So this is what I mentioned just now, isn't it? I mean, TVS, young people, if you want to make diagnosis over young people, if you need TVS, we don't have TVS for young people. So we have to base on symptom. We can start the treatment work, okay, that will continue on, just monitor the patient. But if treatment doesn't work, then we have to revert for diagnosis laparoscopy. No choice, because we need to have a look. We need to give the patient a diagnosis. I mean, can you imagine that patient actually has been sick for many years without a diagnosis? So they also want to know, they need to have legitimate diagnosis so that they can have legitimate MC. And people don't think that they're malingering, they're acting out, they're what do you call this? People say they're just deliberate, something like that. Their symptom.
Lazy.
Yeah, lazy, and they get all this kind of label, and then Indianitis and so on. So, I mean, this is so important. So we need to give them a diagnosis. Okay, most of the time, I see in my practice, I have seen these people. You see, sometimes you can see their face. It's so pitiful because why nobody wants to believe them anymore, and they also don't want to see anymore, because you see they come with the pain and even they don't understand. They get confused. Okay, this is just ultrasound. It can be very high positive predictive value. You see, this is when they have deep endometriosis. Look at that. They can also make a diagnosis of this deep endometriosis ultrasound. Actually, it's a very good transvaginal scan. That's why some people who are the proponents of ultrasound believe that ultrasound can take over laparoscopy. But I think, in some places like in Italy, they are very good at ultrasound. So they can perhaps in this position. But I think in our place, we're still far away from this using ultrasound as a modality to treat solely or to diagnose solely endometriosis. So these are the things.
Sorry, when you prepare a patient for diagnostic laparoscopy, do you prepare them for treatment option at the same sitting?
Yes. So the thing is that, you see, when you go in, there's no such diagnostic CC go. No. So usually you go in with the preparation. If there is endometriosis, you're going to resect. But usually, we're going to resect. But usually, if you have to plan to do that, my practice, in fact, it is also encouraged, recommended, if you plan to go in as operative laparoscopy, I mean that you're going to plan. So you need to do MRI. We need to map the disease. We need to find out where is endometriosis. We need to find out, because we cannot go in, just want to check.
Okay.
So of course, if the MRI is negative, so there is a possibly having a superficial endometriosis, which you can also resect the peritoneum. So that also can cure their pain. At least the idea is that we can biopsy, give the patient diagnosis. Then after that, we can treat the patient, as a surveillance and, continue the hormonal treatment and so on. At least the patient will feel, at least finally someone make a diagnosis. So I
Okay.
think that's how it is. So this is how the algorithm look like, so you do clinical vagina examination, imaging, ultrasound, MRI, sign of endometriosis. Okay. So this one, you want to look for any deep endometriosis or not. Okay, whether involve the bowel or the bladder. And then, you may want to do, if this, you do empirical treatment and it does not, no symptom improvement, you want to explore peritoneal endometriosis. That's why you need to do diagnostic laparoscopy. You have to refer. So this is how the algorithm like. So, okay. So now I'm just giving you the summary. I have a lot more, but I want to give you, this is what the consensus statement, Strasbourg recently, diagnosing endometriosis is what the top, the experts say in consensus. I was the only one in Malaysia representative, and I also part of the contribution of this consensus statement. So that symptom, clinical examination, and TVS are the first line investigation of pelvic endometriosis. So this is consensus statement. Imaging is important for management of pelvic endometriosis and for counseling the patient. So it's very important, you must have. TVS and MRI require knowledge of endometriosis. See, but the problem is that even MRI, our radiologists sometimes cannot read endometriosis. That's the problem. They are not used to read. They are unable to diagnose endometriosis. So this need a lot of training, need a lot of awareness. Young women with severe dysmenorrhea, more than 5, deserve ultrasound or MRI investigation. So you need to take. You cannot just get just another period. Everybody also have. So you have to do ultrasound if you can. If you cannot, you have to refer the patient for gynecologist or MRI investigation. Okay, now I come to the management. Okay, we settle the symptom and we settle this one, endometriosis management. Okay, the management, if you look at this, is what the ASHRAE guidelines, algorithm of how we manage endometriosis with no infertility intention, like young people like that. Okay, no immediate desire pregnancy. So if they have pain, then you want to look at that. You want to pain, so you want to manage this pain. So you want to give this the treatment. Of course, first line COC, second line is GnRH. So you want to actually manage them as a long term. So it's a long term. You want to make sure that they continue on until they want to get married. Because you know that when they stop the medication, the pain will come back. Not like treating a 3 month and then after that the pain better and then stop. It's not like that. So it's a long term thing. All right.
What's COC?
Contraceptive pill.
I see.
This we use that to treat the patient, because sometimes we use that to reduce their menstrual blood flow, because again, remember, retrograde menstruation, we want to reduce this retrograde menstruation, and COC reduce the menorrhagia, right? So that's why reduce the oxidative stress and reduce inflammation, chronic inflammation, and so on. So, and then now people talking about fertility preservation, in fact, you can actually discuss later. I talk about this, and then long-term management and so on, so these are the things. So if they have ovarian endometrioma, so maybe they need a surgery. It depends. So there's something that we have to consider whether they need surgery or not. Okay. So, but if they have no pain, asymptomatic, okay, if they have ovarian cyst, perhaps you want to consider fertility preservation, or you can start medical treatment. You have to discuss with the patient. Okay. If they're very big, you have ruled out malignancy. They are not in pain and they are not like growing bigger. They are not, because endometrioma also can damage fertility. So this is something that you have to discuss with the patient. So this algorithm, current medical treatment option, so you have OC, you have NSID, you have progestin like Visan and so on, you have a GnRH, there's so many things, and a long-term management. The strategies is for long-term is prevention of recurrent of pain. So they have to be long-term. So early diagnosis and counseling for lifelong management, maximize medical therapy, minimize the surgery, mean that you want to reduce the number of surgery by continuing. If they are okay with that medication, there's no side effect, they are compliant, continue so as long as possible. that you can minimize the surgery. If they need a surgery, you want to do, these are very important, is the surgery that only one that we want to do in that period of reproductive life, because we doesn't want to damage the ovarian follicle. So then it has to be done with by the right people. And the prevention of recurrence, if you have done the surgery, you want to prevent recurrence, and of course you want to achieve long-term quality of life. All right, so of course these are the guidelines of the what are you can use. So you see, and then they are all thing, and this is a consensus statement. Okay, again, a consensus statement is said hormonal medical therapy or pregnancy or menopause only inactivate endometriosis. Only inactivate, mean the disease is still there. It's only make the disease quiet. Okay, but don't ever tell the, yeah, because pseudo pregnancy, right? There's no estrogen, right? When you give patient OCs, progesterone, you know, so you reduce their estrogen level, right? So the estrogen, so the women and reduce the bleeding. So that's how it helps. And also pregnancy, also like, you know, when you're pregnant, you have high progesterone, but you have basically no estrogen or low estrogen, same with menopause. But the thing is that they are not what do you call that, absolute, because pregnancy, for example, the patient is a progesterone resistant, the patient can see the disease can see. I have seen the patient in pregnancy also have endometriosis. So it's not like, so it's the term like, oh, when you get pregnant, disease get better. So don't tell the patient that anymore. Never ever tell the patient, okay, when you get pregnant, or you try to treat endometriosis by asking the patient to get pregnant. So this is no longer acceptable, because it's not everyone will have a disease symptom-free when they get pregnant. Because again, by the theory of progesterone resistance just now, okay? So during medical treatment, some 30% lesion progress despite treatment. So again, this medical treatment, they are not absolute. Again, 70% only work. Can you imagine that? 70% only work, 30% it doesn't work. Lesion continue to progress. Therefore, during treatment, at least a yearly follow-up by ultrasound should be done. Because sometimes you realize the patient, if you're on OC, by the time 1 year you see the patient, they already have deep endometriosis, especially if they are progesterone resistant. So they already have a severe disease. And almost 20 to 30% of women with endometriosis and pain do not respond to medical therapy. This is consensus just recently. You know, I went there, when is it now? In July. So almost 20 to 30%. Yeah, 20% to 30% of women with endometriosis and pain do not respond. I mentioned that now. Placebo effect of hormonal medical therapy is estimated at 20 to 30%. Imagine that placebo effect. When you give the medication, they can have placebo. Not medication doesn't work, but placebo effect work 20 to 30%. Efficacy, this one. The people always argue, the drug company and this and that, or say, oh, Visan is very good. You know, now Visan like become #1. Like everybody think that Visan is going to like magic drug for them. Now the study, I mean, these are the consensus that we have sit down and look into all the evidence, okay, before we come to the consensus. The efficacy of all estrogen progestin are similar. It doesn't matter what you give the patient. But be careful if you give them estrogen component, because again, if patient is progesterone resistant, you might actually induce the severe disease. Hormonal medical treatment to abolish menstruation should be considered. This one people talking about, maybe don't have period better. No period better. Maybe we should take hormones, you know, from the beginning to the something like that. Okay, so these are interesting. Okay, so we still have time, Betty? Because
we have just some questions. Can we just answer some questions first?
Okay.
Okay. So from Dokwiti, Dr. Noraisha asked, when is the best timing detecting endometriosis with TVS ultrasound? Is it during menses?
See, the best timing, actually any time is the best time, provided you can do the, you can do the TVS. If you can put in the TVS probe into patient vagina, even I do in patient bleeding, I will still do this thing. But the thing is that why the TVS, what you can detect is you're not going to detect subtle lesion, typical lesion. All this it cannot be seen by the transgender scan, but you can see endometrioma. You perhaps can see some retrovaginal or nodule, something like that. So these are something, and you may see adenomyosis. by the ultrasound. So, okay, things like that. But the thing is that to detect rectal vagina, nodule and this and that, endometriosis require skillness. There have to be some skill. So yeah, they're only sensitive with that, but then they are not going to detect all these deep, those typical lesion cannot be seen by the ultrasound. So any more questions?
Oh yes, there's quite a few questions. So basically what you're trying to say is the timing of the menstruation cycle doesn't determine the best time when you can do
Anytime, yes.
Yes, anytime. So Dr. Cindy asked, what is the COC of choice for endometriosis?
I already mentioned this. There's no, everyone is the same. All estrogen, progesterone, it has been seen, efficacies, everything are the same. That's according to the evidence that we have examined up to now. So far, none, even though drug company will come tell you that one is higher efficacy and this one they make comparison, but I mean, I'm telling you, and consensus tell now, we haven't published this consensus, actually it's really hot from the oven. I just received the whole summary last week. So, and the thing is that we have examined, and these are the top endometriosis and the researchers and this and that. And they said estrogen, progesterone, they are the same efficacy. So it doesn't matter what you use. But I'm just mentioned just now because there is some incident of progesterone resistant.
Okay.
So for those patients, if you give them COC, it means that the patient going to get estrogen only, even though you give them progesterone, because progesterone resistant, right? So that estrogen component going to activate the disease.
Okay. So another doctor asked, Dr. Chan asked, and the improperly treated endometriosis turn up to be leiomyosarcoma?
No, I don't, there's no such a report. If there is, it's sporadic, but it might not be related. But there are two cancers that are related.
Understand the question. I think Dr. Chan is asking whether it could be a misdiagnosis or whether is endometriosis likely to turn to leiomyosarcoma. I cannot.
No, leiomyosarcoma is a muscle disease of the uterus. Adenomyosis, yeah, we're talking adenomyosis, yes, but the thing is that there haven't been any reported as such, because their pathogenesis are different. But there are cancers associated with the endometrioma, like clear cell, carcinoma of the ovary, and then endometrioid adenocarcinoma of the ovary. So they are actually, it has a link. Yeah.
This link that you said, is it a transformation of the cell, or it is because of maybe inflammation that is ongoing for a long time, and then therefore they have developed cancer in that sense?
There is something that they call it transformation but their risks are small.
Okay, can I ask you another question? Dr. Cindy asked, if we already started patient on COC and she plans to get pregnant afterwards, how do we manage the endometriosis while preparing her to get pregnant?
Okay. So when you already started her and this thing, when she got pregnant, just stop and inform the patient, okay, that you're going to stop the medication. And then if she doesn't have any kind of obstruction, the tube are normal, no endometrioma, the endometrioma is not like more than 4 centimeter, less than 4 centimeter, yeah, okay. So she's not in pain, any pain, so she's comfortable. So you can give her, like, whether you can allow her spontaneous and see, because sometimes people, they stop and then they got pregnant right away, right? Because the disease now, the first 6 months before the disease really making a comeback, it's very quiet. So chances of they getting pregnant perhaps is better in the first 6 months. So that's what you give them. But of course, you tell them, okay, there's a risk of that the symptom of endometriosis might come back. So, and then you can ask the patient and find out whether if the tube is both, the tube is not patent for some reason, then perhaps you want to offer the patient IVF straight away. So there's no benefit. Okay, this is something very important. This is also brought in during the discussion at the consensus. There's no benefit to do IUI in the patient with endometriosis because the IUI, the result is so low, less than 15%, and it outweighs the risk of endometriosis recurrence. So it means that, because of they're going to put on hormones, IUI, you're going to give patient these hormones and all right, so you can actually flare up the disease. If the patient get pregnant, high chance pregnancy is never mind. But the thing is that the risk of patient getting pregnant with IUI is so low, so it outweighs the risk of patient getting disease recurrence. So straight away IVF, perhaps, usually the first line now, people talking about IVF straight away. If the patient have the budget lah, or the patient, you can refer the patient to the center for IVF. Whether, this is something you have to tell the patient, whether the tube obstructed or not obstructed.
Okay. A lot of questions coming in. Ashwin, Dr. Yeo asked, what's the cure rate of resection of endometriosis? And what is the percentage of relapse after resection? Does dysmenorrhea every month for the last 3 months warrant a gynae referral?
Okay, last question, yes. It's more than 3 months, your medicine doesn't work. 3 months, the period, the pain score doesn't reduce and still above 5, or to 7. Yeah, they weren't referring. You have to make a diagnosis. We don't want to give people pain for a long time, right? We need to find the reason why they're having pain. So on the other question, on the rate of resection, that curing, that one is depend on skill. Again, skill to do clearance of endometriosis, especially deep endometriosis, varying, and there are very few people only can do it in Malaysia. Okay, they're not deep endometriosis. You have to open those spaces. You have to look at it. They need endometriosis dedicated gynecologists. So to be able, in fact, now it's also discussed in the consensus. Things like that. So of course, even with the disease that you clear the disease. Why the little disease? Because the chances of this patient getting pregnant after you clear the disease, even if you have to resect the bowel, you resect the bowel. If you have to resect the ureter because it infiltrated ureter, deep endometriosis, you resect the ureter because you need to clear the disease. But the thing is that why is it like that? Because there's 50% chance of this patient pregnant spontaneously if she has infertility, and of course she will have pain-free period for a long time. But the thing is that it go down to the etiology of this. How did she get? What is her predisposing factors getting endometriosis? So if she going to get, she got a problem with the microbiome, she got a problem with that, she have a heavy menstruation, all this kind of thing. Of course, she going to get a new lesion. It's not recurrent. It's not like it's an old lesion. It's a new one. If the previous operation is cleared, but again, most of the time, I think in our setup, is still the problem is that, the people not clearing their disease and perhaps just leaving it behind. So these are the things. So there's no such kind of percentage, what percent we can clear the disease and percent it can be recurrent, because the disease itself by nature, because we are not treating the biological cause of disease, we are treating the complication of the disease. Okay, we are clearing the diagnosis, the fibrosis, clearing those clonal whatever activity, inflammation is, and that putting back the anatomical organ into anatomical position, and with that, that reduce the pain and improve fertility outcome.
So basically, you are saying that even when we clear the disease, the new recurrent may not be a recurrent, even though it's the same disease, but it's actually a new development of.
It can be new development, or it can be due to fibrosis due to your operation.
I see. Okay. So I think we will wrap up soon. We will probably have to invite you back to speak on the further slides that you have, because we took a lot of questions today, and I think it is has been a very informative session all the nurses, can you stop share, please, Sharifa? Because I
Okay, stop
share
sharing.
my QR code, yeah?
Okay, I'm going to stop sharing. Wait,
Yeah.
how do I go? Stop sharing.
Okay.
Wait, stop sharing, right?
Yes, at the bottom there, just stop share.
Share. Stop sharing.
Okay. So for all the
Did
nurses
I?
out there, go to Facebook Beating Hearts page and you can get your QR code registration form, your eCert registration form, register there and we will send you the eCert later. So with that, we will stop live stream and then I will share the screen for this one. Okay, this QR code, okay, anyone who wants to buy indemnity insurance, anyone at all, you can try Dr. Shield and the promo code is HEARTS 2021, you get 5% discount. And this is actually the QR code for doctors. So you can also do it and you can get 1 point. And if you need more points, you can actually get 5 from as a presenter. So, yes, so I will put you in. Okay, so if you can't, okay, I will stop share now. I'll stop. Okay, if you can't cannot scan the QR code, then please message me at 012-712-3348. Give me your name, your email address, your IC and MMC. We will have to do it manually. Okay. So thank you very much, Sharifa. I would love to catch up with you and know about you. When I go to Johor, I will catch up with you.
Please come to Johor. Johor is a nice place.
Because I'm so curious about you.
Come to Gleneagle Hospital, Medini. Okay.
Yes, I will check you out.
And
and you don't do obstetric now, right?
No.
You just do gynecology. Okay.
Yeah, mine is focused on endometriosis.
Oh, you only focus on endometriosis.
Yeah, menstrual disorder and endometriosis now.
Oh, so other things you don't do?
MIS for, any estrogen induced disease, like all those big fibroids, and I do advanced MIS. So most of my colleagues cannot do those difficult cases.